for my PSA last week, and it came back as a .01. So the doctor says, I'm cured, but I said, don't rejoice, because we don't consider you cured for 15 years, not 5.
Oh, that's...
I'm 82, so I don't...
Wow.
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 I'm John Lombardi,
That's what he said.
45 treatments, radiation treatments, 45 days, about 18 months ago.
Okay.
And my BSA is a point decimal. It's up and down a little bit, the decimal.
The bounce, yep. Good.
Oh, Clyde, do you want to do it again for the doc turn?
Well,
Gentlemen at the back table?
we can do whatever you guys want to do. I'm really here for you guys. If you're
You're all set?
comfortable.
Doctor, thank you for coming out.
Pleasure's mine. I apologize
Appreciate
for the
this.
delay. We were ended up somewhere else.
I ran across the yard to find him.
To do that.
Okay, David, would you like to say something?
All I can say is that Dr. Akary gave a great presentation at our Sarasota Memorial meeting about 2 weeks ago, and it just made sense for him to come and talk to you folks. I think he's a font of information that I haven't heard from any urologist, and we've had many speaking over the years, so I think he's got an awful lot to say, and he'll tell you the truth quickly. No beating around the bush.
Thank you.
Thank you, Doctor.
Appreciate it. All right. Now that brings us to the question, where do we begin? One of my favorite sayings, I don't know if I said this last time, is how do you eat an elephant?
One bite at a time.
One bite at a time. So, where do you guys want to start with this elephant?
I think one of the notices I saw for this session mentioned that you'd be covering treatment options for prostate cancer.
Okay, discussing the treatment options. I see some familiar faces from last time, so humor me if I'm redundant. Okay? I'll start from the beginning. Treatment options. Treatment options, that's such a big plane. It just includes so many things. And it all starts with something very specific. What do you have? Notice we mentioned earlier, I asked, what's your Gleason score? What's your PSA? Okay? That changes the ballgame. That changes what we need to do to you. Okay? Just because we have a million things we can do doesn't mean we need to do a million things. Okay? A Gleason 6 prostate cancer is a completely different beast, completely than a Gleason 10. Okay? Sir, I'll be honest, I'm just saying it right now, I commend you for you're a tough guy, okay? Usually Gleason 10s, we don't see them lasting that long. You are a lottery winner. Honestly, I am honored to be in the same room as you because that is very impressive. And that's why I'm trying to show you the scale of difference. Gleason 6 may never bother you your whole life. Gleason 10 is a completely different ballgame. Okay? So the first question we ask is, what's your Gleason score? Alright? We break them up into several levels. Gleason, the lowest risk, which is Gleason 3 plus 3 equals 6. Okay? Again, I know I mentioned this last time, but let me mention it again. What does that mean? What does 3 plus 3 equals 6 mean? Okay? The first number is, if I was to tell you that a normal prostate cell, a normal one, looks like a 1, the number, okay? And a very bad cancerous one looks like a 5. A 3 is somewhere in the middle. Okay, does that make sense? So, a Gleason 3 means it's about 2 shades of variation away from what a normal cell looks like. A Gleason 5 looks like a completely different cell. Okay, so the first number is what is we're going to call it the ugliest cell they find on your biopsy. Okay, the second one is what is the most common one. Okay, meaning when we look at all the cells, what is the most common cell that you show? Add them together, that's your Gleason score. All right? So when I ask, a 3 plus 4 versus a 4 plus 3, you see why that makes a difference, okay? Because the ugliest cancer cell that we find, that's the one that's going to determine your treatment. All right? Anything less than a 3 is not really considered cancer. That's why you won't hear somebody with a Gleason 5. That's not cancer. Okay? So, because a 2 and a 3 does not warrant to be justified as a cancer. Now, if you were diagnosed about maybe 25 years ago, we found that a lot of people were actually being diagnosed with cancer who were actually Gleason's less than 6, and it wasn't really a problem. It wasn't something that needed to be treated. So this is one of the things as we've kind of normalized, and all the pathologists look at it the same way, that's helped significantly kind of making sure that across the board, your pathologist is going to agree with his pathologist as to what Gleason score it is. Now, that being said, not all pathologists are created equal. I'm going to be quite honest with you, okay? Pathologist is somebody whose job is to look under a microscope at cells. He could be looking at bone cells today. He could be looking at hair cells the next day, or skin cells. I always recommend, and I always like my path to be reviewed by a guy who has dedicated his life to nothing but prostate. That's all he lives for, okay? Those are the guys that are usually the most consistent. All right, so in this area, for example, I like it to go to Moffitt, okay? Moffitt, usually we send it to Moffitt because there's a GU pathologist there. That's all he does. He's dedicated to that. So, and why is this so important? For the very reason, everything we're going to talk about from this moment on depends on that's one of the initial numbers. Okay. Next thing, PSA, the wild number. Okay. It comes up and goes down. Does it mean something? Does it not? It's controversial. Bottom line with PSA, if your PSA is absurdly high, okay, basically once you start going past 20, that's never normal unless you have a really bad prostatitis or something else, okay? So even if your Gleason score is, for example, a 7, but your PSA is 20, that gives me heartburn, and I'll still give you the workup as if somebody who's high risk. Okay, so that's where the PSA comes in. It's kind of like a marker. Forget about the absolute value. It's more like if it's really high, a normal prostate should not have a really high PSA. Okay. Now, I'm going to come back to the Gleason score a little bit. Some of you, when you got your biopsies, if you looked at your pathology sheet, it showed that you have something called high-grade PIN, okay? Some of you said it had something called ASAP, atypical cells, okay? They've done research on this, okay? People with high-grade PIN, what we do with them is we do a regular follow-up with PSAs and with DREs. That's the official follow-up from a couple of years ago. Now, with MRI prostates, we do an MRI. Okay? People who come back with atypical, ASAP, if you've seen that before, okay? Those people, the guideline is actually biopsy you again in 3 months. Okay? Now, that's fine, but again, in this day and age, I recommend always MRI, then a biopsy. Meaning what? We said this last time. Why would you just randomly take biopsies when you have the opportunity to be a sniper and specifically aim for it? Okay, why? It just doesn't make sense to me. And if you have a negative biopsy in the setting of an elevated PSA, the insurance company pays for it too. So there's no need to do it in the office and just do another random biopsy. It's absurd to me, okay? Some of you may have heard, oh, this guy got 28 biopsies. He got 28 cores in their biopsy, okay? Why? I mean, that's World War II style, like carpet bombing. That's exactly what it is. I call that a percutaneous prostatectomy. Okay? That's exactly what it is. Why? There's no need for that. Get your bullseye, aim for it, take your biopsies. Okay? Now I'm going to give this disclaimer because this just happened to me recently. Gentleman got an MRI prostate. His PSA was normal, but his primary ordered an MRI prostate because the group that they're in owns an MRI machine and they were able to get it through insurance. Okay, now remember I told you the only way Medicare, when I say insurance pays, I base everything I say on Medicare because I feel like that's the kind of the baseline that across the board. If if you have something else that's great that pays for everything. So they got an MRI prostate, but the gentleman who read it is a typical radiologist, not a specialist in MRI prostate. Okay? He measures on his evaluation a PIRADS 4 lesion. Okay? Real fancy word for higher likelihood of it being cancer. Okay? And I got a nice bullseye to target. We do a targeted biopsy. Now, there's no ifs, ands, or buts about a targeted biopsy because actually you take a video as you're shooting straight into the heart of it. Okay? There's no doubt that you got it. Pathology comes back, completely benign. How did you just tell me it's a PIRADS 4 concerning biopsy and I just got a negative biopsy? Okay? Let's just say we I actually walked over and went and sat in his office and me and him had an interesting conversation, okay? So, as a result, okay, and this is what we used to do in Tampa, all right? There was one radiologist who specializes in doing MRIs for prostates. He didn't have this problem because that's all he did. He wasn't a guy who did everything general. Okay? And that's who we had read it. And then I went ahead and sent the CD up to him, and guess what he read it as? And by the way, I did not send him the report. Guess what he read it as? Okay? So, what's the moral of the story? Whether it be the pathologist, the surgeon, the radiologist, it needs to be somebody who does a lot of it because it is very, very intricate. Prostate cancer. It's a beast of its own. All right. Now, let's go back. Treatment options. For those of you who talked to me after the last meeting, okay, once you answer, what's your PSA? What's your Gleason score? I am automatically reference, and you guys are going to get tired of me saying this, the NCCN. Okay? And I'll repeat it again. Okay? I abide by it. Okay? So, for example, if somebody, let's say, for example, I diagnose somebody with prostate cancer. I get their pathology back. I see it. Okay? I automatically do a couple of things. Number one, there's something called a Parton table. It's a table that is basically a summary of basically a cohort of people who had prostate cancer. They gathered what their Gleason score was, how many biopsies were taken, what percentage of each biopsy was cancerous. I enter all of your information. And it gives me percentages of the following. Based on that criteria, what's the chance that it's spread outside of the prostate? What's the chance that it's in the lymph nodes? Okay? What's the chance it's gone into the seminal vesicles? What are the seminal vesicles? They're the two little tails that form all the juice that the prostate makes. Basically, when you ejaculate, okay, a lot of that juice are stored in those seminal vesicles. And we have found that people who have invasion into the seminal vesicles, that's a bad prognosis, okay? That now you're on even more heightened alert that this is something's a little bit more aggressive. So you get percentages for those, all right? So the first sheet is your pathology sheet. Second sheet is your risk sheet. Why? Because I want you to know exactly where you stand. Okay? It's a difference between somebody who has a higher likelihood of metastasis versus somebody who is all locally confined. That's number 2. Number 3, I literally print out the page from the NCCN guideline, which basically I ask you the question, PSA Gleason score, and I automatically put you in a category. Okay? As we said, in your case, unfavorable intermediate risk. That's defined by those 2 things he told me. Okay? I can go across this room between every single person who's been diagnosed. I can tell you what your risk is right now. Okay? And based on that, it's literally already a well-defined flow of what needs to be done to you. Meaning, what workup should you get? Does every single person who needs prostate cancer need to get a bone scan and need to get a CT? No. It depends on the risk of spread. If you're labeled as high risk, or even if you're intermediate risk but a really high PSA, yep, you're getting it. Does a Gleason 6 get it? No. Does a Gleason 3 plus 4 get it? No. Doesn't need it. Okay? Because the chances of metastasis is not there. All right? And based on that, there's a series of what are your surgical or non-surgical options. All right?
This is all in this Parton table?
This is in the NCCN guidelines.
Oh.
Okay? And I actually, from our last meeting, I called them and I asked them to send me patient handouts so that I can start giving it to everybody, because I truly believe you need to be the most educated person about this. In the story you gave, sir, the biggest problem in it, and you probably are getting the right treatment, probably, is you're left in the dark. You should not be left in the dark. You need to be in control, because this is your life. Okay? And that's what I want, hopefully, these meetings to be about. I want you to be in control and at the same time figure out how we can manage the disease and maintain your quality of life. All right. So now, does everybody understand what the NCCN is?
I would ask you to
Repeat it? Okay. The NCCC is the Comprehensive Cancer Network. All right. I want you to think of every single big cancer fundraiser you've heard of in your whole life. Think of the names that you heard. Sloan Kettering, okay? Dana-Farber, Moffitt, UCLA, UCSF, Mayo Clinic, Cleveland Clinic. What are all these centers? These are what we call tertiary care centers for cancer. Basically what? A whole center dedicated to nothing but cancer. Okay? Meaning what? They have the largest volume of patients. So what they do is they take all the information that they've learned over the years from these patients and dump it into a big data pool. And then they start making algorithms because, for example, somebody who's a Gleason 8, at some point, some of them got radiation, some of them got surgery, some of them just got hormone treatment, all right? And they followed them over years and they saw what the outcomes were. And based on that, they figured out which one is the best intervention based on your pathology. And the thing that really determines it, your initial pathology. Okay? So they compiled this data. So, and out of all these institutes, which is excellent. So now we can get an idea of somebody who's in a very similar situation as you. What's the best option for you? Okay? So the next thing I do is I print out that page. Okay? This is where you are. Oh, so the first fork in the road is what's your average life expectancy? Okay? It changes the treatment. If somebody's 95, okay, and he just got diagnosed with prostate cancer, do you really think you should be giving that person surgery?
No.
Some people do. Okay?
Surgeons.
So die. It is the flock, yes. And it goes with basically, remember, if you go to the carpenter, he's going to tell you your door needs to be fixed. If you go to the welder, he's going to tell you it needs to be welded to be fixed, okay? But what I like about the NCCN guidelines, if you're honest about it and you educate the person in front of you, it's your decision and you guys need to make that decision. okay? Because guess who's gonna be left holding the bag in the end? It's you guys. So you need to be very well educated on it. All right? So we'll try to say it in the most unbiased manner. All right? So the typical options go as follows. All right. If you are one of the lower risk or favorable intermediate risks, you will most likely not need androgen deprivation therapy. Okay? I know we talked about this last time. Let me talk about it again. Androgen deprivation therapy. What is it? I'm giving you menopause. No better way of saying it, okay? For those of you who have been married, if you remember how your wives were when they were in menopause, it's exactly what we do. It is literally the definition of what we do, okay? You will have the hot flashes, you will have the fatigue, you will have the moodiness, okay? So all of that will come about. But the same way it varies amongst women, some women don't even know they're going through menopause. Other women, it's hell on earth, okay? You men who get androgen deprivation therapy, it will vary with them as well. What does it do? Real fancy way, kill testosterone in your body. Why is it important to kill testosterone? Testosterone is the open buffet for prostate cancer. And that if we kill the testosterone, we can starve it. Okay? So, now, for example, somebody who is unfavorable intermediate risk, you'll notice that when we look at the chart, it says plus minus androgen deprivation therapy. What does that mean? You can have it, you can't have it. There's no official thing you need to do. Because basically what it means is we should watch you if you need it and offer it to you and give it to you as needed. It does not mean you 100% need it. As opposed to somebody who's high risk, no ifs, ands, or buts, you need it. Okay? And when I use the word need loosely, we have found that it gives you the best outcomes. Recommended. Because in the end, it's your choice. Okay? If you don't want to deal with it, that's fine. Okay? As long as you understand the outcomes and the risks of not doing it. So, that's the androgen deprivation therapy. Now we talk about the big blocks. Okay? Surgery, radiation. That's really what it splits to. Okay? Surgery is surgery. It's all robotic. Robotic is the standard of care. It's 5 basically incisions in your belly. You go in, and here's your bladder, here's your prostate, here's the base of your penis. Okay? Go in, chop the prostate off the bladder, chop it from the base of the penis, take it out. All right? I wish it sounds robotic and it sounds like it's something from the Jetsons. That's all what it is. Okay? Now, if you're a higher risk, they don't just take out the prostate. We take out the nodes that are next to the prostate. What is that? Your whole body has a drainage system. Okay? They're called lymph nodes. And we found one of the first places it likes to go is in those lymph nodes. Okay? So what do? We take out those lymph nodes if you're high risk, because if you're high risk, the chances of it being in the lymph nodes is higher. That does 2 things. Number 1, it helps if the only place it went to is those lymph nodes, we took them out. All right? Number 2, it lets us know it's in the lymph nodes. This guy's got cancer that's spread outside of the prostate. That automatically tells us this guy needs to be automatically on the androgen deprivation therapy, period. Okay? Because it's no longer an issue of something confined in the prostate. It could be something microscopic anywhere in the body. Hence, the only way to treat something systemic is with systemic therapy. Okay? So that's the surgery. Pros and cons. If you're one of the people, and it's a personal thing, I keep coming back to it's a personal thing because I really want you guys to look at it in that sense. If you're one of those people who worries, is always going to be thinking, I have cancer inside of me, I have cancer inside of me, get it out, that's the person I recommend to get surgery. If you're not that person and you can sleep at night, you don't need to get the surgery, okay? In terms of the surgery, you will come out of the surgery with a catheter, okay? Why? When you take out the prostate, we kind of scoot the bladder to the base of the penis and we tie it down. Well, it takes about 2 weeks for that new connection to heal up. All right? So, you will have a catheter to minimize any pressure in the bladder during that time. That's number one. I've had a couple of guys tell me, I don't want a catheter, keep that thing away from me. And they've literally chosen radiation for that sole reason. Okay? I'll be honest with you. Everybody's different. Next thing. Remember I told you it's bladder, prostate, base of penis? Between the bladder and the prostate is the first valve that controls your continence. Okay? After the prostate, about a centimeter after the prostate, is your second valve. All right? Part of the surgery is destroying that first valve. You have to cut it. No ifs, ands, or buts. Okay? But you're left with one valve that can still work. All right? So, as a result, now there's one valve doing the job that two valves did. It takes time for that valve to pick up. And also, naturally, as we get older, our muscles and everything fatigue. That's part of getting older. So that valve isn't as strong as it is. Which is why you'll see in the guidelines, somebody who's older, when I say older in the guidelines, like 75 and above, the typical recommendation is radiation. Okay? For the reason of the incontinence issues is one of them. Okay. Now, we suture it back together. You take out the catheter, you're floridly incontinent. You're just incontinent. Okay? Everybody's different depending on the kind of cancer you had. Okay? And I'll come back to this. The nerves for the penis and the erections travel on the outside of the prostate. They are sitting on the prostate. Okay? If you have a high-risk prostate cancer, then always remember one thing. The name of the game is get the cancer out. Everything else is secondary. Which means what? If there's a higher risk of it going out of the prostate, you take wide margins. Meaning what? You're taking the nerves for erectile function. You're taking them. Okay? Now, if it's a low-risk cancer, like a Gleason 6 or a Gleason favorable Gleason 7, you can carve and push the nerves to the side and just take out the prostate. So, erectile function will be affected. Okay? Continence typically comes back within 4 to 6 months. Some people it takes a year. I'm a big believer in plan for the worst, hope for the best. So, I let people know, are you okay with the chance of you being incontinent or needing a diaper for 6 months to a year? That's a choice. Okay? Some people say, hey, as long as you get the cancer out, that's fine. Some people say, nah, it's fine. I don't want to deal with that. Personal choice. Okay? And as I say all these things, I want you to remember something very specific. None of the perceived techniques that I'm telling you about has been proven to be better than the other one. Okay? All are pretty much equal. So these are all choices that you as an individual has to make. All right. Yes, sir.
If in the example you just covered, the patient has incontinence that because of the surgery and what you're removing and shoving around and all that? So that if that patient had radiation, he would not have that problem?
So the
Maybe not.
official, no, that's a good question. So the official statistic on radiation is that the degrees of incontinence are relatively similar. Oh, thank you. They're similar, okay? But with radiation, you still have the two valves. I didn't cut one out. It may be weaker, but you got two. All right? So the official research, remember, every single thing I'm gonna tell you, there's a research study confirming it. None of this is my opinion. I don't believe in opinions in cancer. My opinion is worthless. Okay, honestly. I believe in statistics in terms of what has been shown to be proven to be effective and the reality of it. Okay? So, and with radiation, depending on how they zap and where they zap, will the sphincter be affected? Yes. How much it's affected depends on where your cancer was. If your cancer was in the middle of the prostate, they really are doing a pretty good job about focusing right in the middle of the prostate and not having that much scatter radiation go to that sphincter, okay? But always, as I always say, plan on the worst and hope for the best to do that.
Makes sense.
Now, is it immediate with radiation? No, it's not. You're not cutting out a whole valve right off the bat. You're zapping it, and it takes time for you to start to see the incontinence. All right?
It gets better over time.
And it does. And big why?
You speak from experience?
Yes, sir.
Yeah. And I'll tell you why. So this
First
is
4 months are, to me, were very challenging. But after 4 or 5 months, you come back to life, and life is good.
And I'll tell you why. And the same thing happens whether you're in surgery or radiation. Everybody here has heard of something called Kegel exercises?
Yes.
Okay? What is that? It's something we hear women do. Okay? Why? So ladies only have one valve. Okay? The rest of their control is done by the muscles of their pelvic floor. Okay? So what do Kegel exercises do? They train you to strengthen those muscles. That's why a lady after a delivery, after a pregnancy, we train them to re-strengthen those muscles. Well, guess what? If you had surgery, you're down to one valve. If you had radiation, you still have both valves, but they've been weakened by the radiation. So what do? You recruit the pelvic muscles that as a man you never had to use before because you had two valves, you didn't need to before, but now you recruit them to help strengthen and improve your continence. Which is why we find true with radiation, once you start to build up your Kegel exercises, continence improves. Because why? It may be two weak valves, but if you subsidize it with strengthening your pelvic floor, it's better. And the same thing happens with surgery. The first thing you need to be doing is Actually, it's funny you say that. In the terms of the Kegel exercises, we send people before the surgery to make sure you know how to do it. Okay? It's, by the way, the most obnoxious thing, because basically you have somebody put their finger in your tush and push on the muscle and tell you, hey, do you feel that? That's where I want you to feel the muscles pull. Okay? But that's the only way, because it's, to us men, that feeling is foreign. We don't use those muscles that much. Okay? And that's how you learn how to do it. So, and it's pelvic floor therapy. There's multiple things we can do. But we like to send people from the beginning to do that. And I'm talking whether it be radiation or whether it be surgery. You should know how to do it.
Doctor, can you touch, if I'm not interrupting, I hope too much, can you touch on proton therapy, cryotherapy, what's the other one, cyberknife and seeds?
Come into that.
Yeah.
Come into that. For sure. For sure come into that. So, those are the main side effects that whatever you choose, you have to deal with. You have to figure out. Now let's start talking about the specific surgery. So we talked about surgery. All right? Is it clear? Any questions about it? All right. Radiation. If somebody says, hey doc, I don't want surgery, all right, let's throw surgery out the door. I want radiation. Radiation, now we're at another fork in the road. What kind of radiation do you want? Okay, oh yeah, it keeps splitting, all right? Now, I'm gonna split radiation into 3 types, okay? Straight radiation, meaning what? Zapping the prostate from the outside. Zapping the prostate with the outside, but at the same time putting in radioactive doses, seeds, pellets into the prostate. And the third one is proton therapy. Okay? Remember, they have all been proven to be equal. Okay? But some of them come up to be options for different prostate Gleason scores. Remember that, okay?
I'm sorry,
So
remember what?
that it's which procedure is available to you depends on your Gleason score, okay? If, for example, some of them are a little bit more aggressive, okay? Like brachytherapy seeds with radiation, that doesn't come up for the low risk people. Don't need it, okay? Just because it's there doesn't mean we need to do it. All right. Now we come talk about the radiation. All right. There's radiation zapping it from the outside. That's one thing. There's, okay, I'm going to give you a lower dose of radiation to lower the toxicity, but what I'm going to do is I'm going to put these little radioactive seeds inside of you and leave it in the prostate, and they're going to kill all the cells around them. And I'm going to give you radiation on top of that to get whatever it does again. Okay? That's the second kind. Then we come to proton, the controversial one. That's not really controversial. Okay? Proton is a completely different type of radiation. Okay? The way instead of zapping from the outside, it does a chemical shift in the cells themselves that causes gradual death to the cells. Okay. Why am I saying it's controversial? For the longest time, people have poo-pooed it, all right, until there is now a study that shows, in terms of outcomes, it is equivalent to the other radiations, okay? It's just, there hasn't been a long enough follow-up in order for us to confirm the side effects, okay? That's it. What I'll tell you about, so one of the things you have to know about radiation, you need to know that the radiation needs to be focused and it can damage structures around it. Like what? If it gets too close to the bladder, it can hurt the bladder, okay? And you can get what we call radiation cystitis. It shows up 4 to 7 years after you get radiation. Yep. If you get it today, I'll see the side effects 4 to 7 years from now, okay? And that all depends on where the radiation hit. So remember I said bladder, prostate, base of penis. If your cancer is really sitting at the back here, okay, close to the bladder, the radiation guy's got to zap that area. And there may be some injury to the bladder, okay? Yes, sir.
Are you discussing right now protons?
Standard radiation.
Standard.
I'm gonna go now and hit the side effects for everyone.
Okay.
This is standard radiation.
Great.
Okay.
Did I hear that if you had radiation 7 years later, there are some?
Oh yes, which is a pet peeve of mine. Okay, why? Remember how we said if you go to the carpenter, I'll tell you your door needs to be fixed. If you go to the welder, okay, when you go to the radiation guy, he'll tell you, oh, side effects are minimal, it's equal to surgery, and that's it. It's not. Why? Because there's side effects that, as the urologist sees 7 years after. 7 years after you got your radiation, the oncologist doesn't even know who you are anymore. He's already done his job, you're 7 years down the road, okay? So, and you've forgotten who they are, okay? Because now you're having these symptoms of radiation cystitis, which is what? You've irritated the bladder mucosa, okay, the inside wall of the bladder, and the vessels start to bleed, okay? And what you'll have is this bleeding coming out in the urine, okay? Usually it takes care of itself. Sometimes we have to go in, find what's bleeding and burn it. Sometimes it gets really bad and we have to send them to hyperbaric oxygen, okay? Does this happen to everybody who gets radiation? No. Okay? But it's a risk you should know about.
Percentage wise, 50% of.
No, it's probably closer to 14 to 20. Okay? Around that range. So, that's radiation. The other place it can zap, I don't know, for those of you who may remember last time, or for those of you who weren't there, here's your rectum, here's your prostate. One's sitting on top of the other. The prostate's sitting on your rectum, okay? And there's this thin layer of tissue in between them, okay? If the radiation goes too far down into the and touches the rectum, you can have the same symptoms that I told you in the bladder, you can have it in the rectum.
Yeah.
You can have irritation, you can have diarrhea, and you can have bleeding in the rectum. Okay. The nice thing about the rectum that we do is something called spacer. Okay, and anybody who's thinking about radiation, I highly recommend you read about it. Okay? What is it? In the office, you get an injection of a material that increases the gap between the rectum and the prostate. Okay? What's the main side effect to it? It lasts for about 4 months, and you feel like you're sitting on something when you sit down. That's the main side effect, okay? But it dissolves naturally on its own, and that's it.
Does it act as a barrier?
It's a spacer, okay? Barrier meaning it doesn't allow radiation to pass? No. Radiation, if it wants to pass, can pass. But the radiation oncologist is very good on controlling the depth, okay? So he can control the depth, and just to make sure that the rectum is far pushed away, just in case if there was a couple of stray beams that went down, that pushes it down. So if the radiation does go past the prostate, it'll go into the spacer, not into the rectum.
Is that what the balloon used to do?
Which balloon?
When you go for radiation, there is, my understanding was like a balloon that is inserted in your rear end.
So what that thing did was, okay, so the spacer actually separates the spacing, okay? What you're talking about is what they would do is actually put something in your tush and push the rectum down.
Yeah.
Okay?
Yeah.
But you're pushing the back wall of the rectum. The front wall is the one that I care about.
Okay.
Does that make sense?
Yeah.
But it helps a little bit.
Maybe it's old technology compared to.
So this is something newer
Yeah.
they're doing, okay? Something to consider. Why am I telling you this? Somebody who doesn't do a lot of prostate cancer doesn't know about it. I want you to be educated about it. Know about it. You have that option. Okay. That's the other thing in terms of the side effect of radiation. Okay. Next, we go into this whole radiation plus seeds, the radioactive seeds. Okay? Does that mean we're turning your prostate into Chernobyl? No. Okay? The radioactivity, the half-life, it dies depending on the seed, usually within 3 months. Okay? It's done with how radioactive it is. Does it work? Yes, it works. Does it minimize the amount of radiation you get? Yes, it does. Here's the side effect that the radiation oncologist doesn't tell you about, okay? And please, I am not in any way telling you one is better than the other one, okay? I just want to set expectations, okay? The seeds, as they kill the prostate shrinks. Okay. Where are those seeds going to go eventually? They eventually start popping into the middle of the prostate where you pee from. 5 to 6 years after you get the radiation, you come into the office, you're getting regular urinary tract infections. Why in the world are you getting urinary tract infection? We go in with the camera, guess what we find? A little annoying seed sitting right there with some incrustations on top of it, that's usually a cause for bacteria. Now I have to go in and pluck them out and try to get all that out. All right? Does this happen to everyone? No. But know about it. Okay? So now we're talking, that's the seed, okay? Now there's another technique that's used where they actually put in raw, basically little syringes, okay? And the tips have a radioactive tip on it. They shine their localized radiation and then they pull them out. Okay, so it doesn't stay. Similar effects as radiation. Okay? That's the radiation with seeds. Proton therapy. Alright? Proton therapy, different kind of radiation. The official recent papers that are out show it is equivalent to radiation. Okay? Here's the problem with the papers that have come out thus far in terms of the side effects. Okay? We all agree in terms of oncologic outcome, meaning how good it is in killing the cancer, it's equivalent to normal radiation. But here's the problem in terms of the side effect profile. The guy who does the research on the radiation says this is the best thing since sliced bread. Guess who does the research on the proton therapy? The guy who does the proton therapy. And he tells you this is even better than sliced bread. Okay? And they're bouncing back and forth to that in terms of what the true side effects are. Okay? But the most recent studies show it's pretty much equivalent. All right? That's the science. Now I'm going to step away from the science for a second. I'm going to come to a zone that's uncomfortable to myself, all right, which is anecdotal. Okay? For whatever reason, people who get proton therapy are passionate about it, okay? And they say they have minimal side effects. Okay? So the patients that I've seen who got it are very happy with it, very passionate about it, okay? And they feel that the side effects are less, or they say they don't have side effects. This is not based on science. This is 100% anecdotal. Okay? Let me step back into the science box. They are equivalent.
Is there a Gleason score that proton therapy is not good for or is good for?
When radiation, so anytime you see radiation as an option, proton therapy is an option. Period. You can substitute them equally. Okay? And then really, remember I asked, one of the things I mentioned is, how are you health-wise? Okay? Not every 70-year-old is the same. Not every 80-year-old is the same. There's a cost you pay for each one of these procedures. Okay? When the symptoms come about, how they come about. Because remember, if you're 82 years old, all right, age of an average American is, right now, let me see, what is it? It's usually 86. Okay? If it comes in 7 years, or the side effects are in 6-7 years, and you're 82. Think about it, okay? And all you have to do is sit in a chamber. You get 3 tattoos, okay, for guiding the beam. And you sit, you get zapped. And I'm not belittling how taxing radiation is, but it's not a big surgery. It's not anesthesia, okay? And you know what? I don't think I was fair in telling you the complications of the surgery. There's always a risk to the rectum, okay, and the surrounding vessels, okay? And it's a surgery, for heaven's sake. There's healing time from it, even if it's robotic, all right? So it's where you're at in life, too, to know. So these are the things. Gosh, I can go on this forever. Tell me, I want to really answer what you got. What is it you guys want to know? Listen.
Really quick. I was under the impression that proton radiation is less, it doesn't penetrate as deeply as.
What you're saying right now is the farce that has been propagated throughout the community. The study says bluntly, and where am I getting this from? The NCCN guideline. In the most recent update, they specifically have in a box saying it has been proven to be equivalent. Remember, I don't care about anybody's opinion. Show me the science. Show me the paper to prove your opinion. Okay? Somebody's life and cancer, we talk science and reality, not your opinion. Everybody can use their opinion on themselves. Okay? Yes, sir.
Dealing with pathology, when a physician is in a group,
Yes.
is it up to the physician to determine the pathologist to use, or is it a business decision based on the agency that they're under, the umbrella they're under?
There's a very good question. There's a very good question. And the answer is it's based on the conscience of the doctor.
Oh, okay, so the physician could say, we're not going to use A, we're going to use B.
Physician, I don't care what anybody says, the physician always has that option in every instance.
Okay.
Okay, but guess what? Your life, you're the patient, you can push him to it and let him know you want a second opinion. For example, there's one of the big groups in Tampa. They have their own pathologist. Guess who they're going to send all their slides to?
Right.
Okay? I'm not saying the guy's bad or he doesn't know what he's doing, but he's going there. Okay? I prefer, this is again, I'm going to step out of the science box. I'm going to say this is my preference. Okay? I like to send it to the guy at Moffitt who does nothing but, who's unbiased, who does nothing but prostate. That's my opinion. There's a guy at Hopkins who does it too. There's a guy at UCLA. You can send it for second opinion. Cleveland Clinic, second opinion.
Yeah, but how would I know who to send it to or ask to send it to unless I went to you and then, you know?
It's very simple. All the big names you've heard, the cancer institutes.
Oh, I see.
All the big names, the cancer institutes, the people who do nothing but cancer.
I picked the phone, I called Hopkins, who's your pathologist who does prostate
Yeah.
pathology stuff? They gave it to me on the
So,
phone.
like Moffitt will
Give
have a
his
guy.
fax number and
He
everything.
just does lung. There's another guy. He just does prostate. That's the guy I want to read my slides.
Okay. So I could come to you and make an appointment, say, okay, who do you use if I ever needed that?
But you never need it.
Yeah.
Okay. But then the question is, when the pathology comes back,
Yeah. Oh, I see what you're saying.
when the pathology comes back, if it shows that there's cancer, there's cancer.
Got it.
Okay?
Yeah.
If it looks fishy, no, give me a second opinion. And actually, I have found insurance companies pay for a second opinion too. Sometimes it's not even something good.
Yeah.
Why not?
Yeah, I've had second opinions and they did pay.
Yeah.
I got one last question. On your MRI, do you use like a contrast agent like gadolinium, or what do you use as a
It is. So you get an MRI, it's a special, it's not any MRI, it's an MRI prostate.
but is it gadolinium?
There is a contrast with it. You do use a contrast with it, yes.
Is there any options to gadolinium?
In terms of,
A contrast agent, because gadolinium is, in my opinion, very good to use in the body. But
well, it depends. So gadolinium has been shown to be safe, except for people who have kidney disease.
and I do.
It depends what your creatinine clearance is. There's a calculation we do. We found the number of 30. Anybody less than 30, you get something called NSF, nephrogenic systemic fibrosis. Okay, the chance, it's a very low percentage of people who get it, but you can get it. All right, those are the people. No, I'm sorry, we're not doing it. That's the one time. Remember, I told you there's the carpet bombers, the people who do 28 biopsies.
Yeah.
The guy that I can't do the MRI on and I can't do the targeted on, that's off the table for whatever reason, that's the guy that I have no other option. You forced me into that position, not as a first option. Okay?
Thank you.
To do that. That's the situation where you do that.
Thank you.
No problem. Yes, sir.
One of the many books that I've purchased to try
On
to
the-
figure
yes.
this out
Yes.
was written by a guy who's supposed to be a real hotshot at Johns Hopkins.
Oh, everybody's a hotshot at Johns Hopkins. That's where hotshots go to.
Go to die of
Yeah,
prostate
to
cancer.
do that.
Anyway, his name's Patrick Walsh.
Dr. Walsh. What is Dr. Walsh known for? Do you know?
He came up with some of the less harmful surgery techniques.
It's exactly what he's known for. So before, what we were doing, just so you know, back in the day, if you know somebody who had a prostatectomy in the 80s, actually there were some people doing it up until the early 2000s. They would go in the taint area, underneath your scrotum, between your scrotum and your anus, cut you right down there, and grab the prostate and close you up.
Yep.
All right. That's what it was. All right. Now the problem was remember I told you sometimes we like to get lymph nodes? You can't get lymph nodes from that access. Okay? But the nice thing about that surgery is the prostate's sitting right there. It's easy to get. Okay? What you guys, I want you to, if you look at your hips, all of you, okay, your prostate is deep in there. When you're operating on the prostate, you're operating at the bottom. You know where the drain is in your bathroom sink? You're operating there. That's why we use the robot. There's nothing special about the robot. The robot doesn't do anything good other than the fact that you can get the camera and the angles allow us to work deep inside of that sink. That's the only benefit of the robot. The robot doesn't do anything on its own. It's not more accurate than a man's hand. It allows better visualization because you can squeeze, you can look down, move around, rotate in all these directions that you can't with a human being on the table. Okay? So Dr. Walsh, his claim to fame is he's the one who basically pioneered the procedure of doing removing the prostate open from here, from the top. That's his claim to fame. Yes. To do that.
Well, you're a little ahead of me because I'm not at that decision point yet. No problem. What I was going to bring up was he, in his latest edition of his book, recommends getting your biopsy results, the slides, read by multiple, at least more than one, pathologist. What you were saying,
Yeah,
in effect.
I agree.
And he gave interesting comments on some of the pathology labs that you find around town. I don't know if that includes Sarah Path, who did mine, or not. But they have had, under studies of this subject, there have been more mistakes in a lot of these yokel path labs. And he says, get a second opinion, no matter what, before you go under knife or under robot or anything else.
I agree. I like to send everything to Moffitt.
I asked 2 urologists about getting that done. Oh, you don't need to do that. There's nothing wrong with it.
Here's what I'm going to respond to that with.
I let them talk me out of it.
Well, here's what I'm going to respond to that. If it does absolutely nothing other than make you feel more comfortable about your decision, then it was 100% worth it. Let's not underestimate
Medicare
the person.
Damned. I don't mind paying for it.
No, they pay for it.
They'll pay for it, and your confidence in the decision you make, we were actually just talking about that on the way in. Your confidence in the decision you make affects your outcome and how you look at things. You need to know that you did due diligence in making this life-altering decision. I mean, I'm sorry, did anybody here buy their house and not get a home inspection? I'm just wondering, did somebody just go and say, hey, let's just do it. I don't need anybody to double check what you said.
I trusted that.
Yeah, you just said, hey, oh yeah, sure.
And the home inspector missed some things.
Exactly. Do that.
Okay, you cleared that up.
What makes you so different than every other doctor?
Oh, my wife can make you a list of what makes me.
What is it that you're doing that you, from what I've been hearing, is a lot different than other doctors that people visited? What is it? What makes you so special?
My wife will tell you I'm special because I took the short bus to school. Okay. I'll be honest with you. I said this in the last meeting. For those of you who weren't there, My background is I'm an electrical engineer. Okay? I actually see myself very much so. I have the mannerisms of an engineer.
Yes, you do.
So as you hear me talking, I break things down because that's how I think. I have to simplify things, get to the root of the problem, and attack the root, as an engineer does. Okay? And I also realize engineering is a pure science. There's a lot of bias that comes into medicine. I'm not going to sit here and lie to you and tell you there's some things that aren't tainted by pharma, they're not tainted by personal opinion and so forth. Things that don't really exist in engineering. If the way you design that bridge isn't working, the bridge is going to fall. There's no ifs, ands, or buts about it, okay? There isn't that much variability. So to answer your question, I really do think that I just look at it as just tell you the facts and respect the person in front of you. I don't like the whole paternal thing where you think that the patient is a child and you're just going to make the decision for them. No, actually, 90% of the time the person's smarter than you, and he knows 100% of the time knows that his body better than you ever will. So give him the information and you make the decision. Does that? Yes.
It took me a while
Uh-huh.
while I was doing my research and searching for other opinions and
Mm-hmm.
to discover there's something called ageism.
Yes.
It took me a while to
Yes.
discover that.
Ageism.
Ageism.
Yeah.
In other words, you're 75, you're 78, what do
You got one foot in the grave, one
Right.
foot in life. Don't worry about it.
So,
That's true. No, that's true.
no, it took me a while to discover that. So then the way I approach doctors is I ask a question, I get an answer, and then I say, okay, doctor, now let's fantasize a little bit. Assuming I'm 55, what would your answer be? And I would get a different answer.
Yep. 100%. 100%.
I would get a different answer.
And these are the biases that come in. Okay. As I said before, is every 80-year-old look the same? No. Okay? No. Everybody's different, and what everybody wants to tolerate is different. So there are these inherent biases that, again, you take them out of the equation when you guys know the facts. Okay? I want you to know the facts. You know to the good and the bad of everything. And then you make a decision. Because if you're truly a physician, this is again my personal opinion. If you're truly a physician, you want what's best for your patient, not what's best for your patient within the scope of what you like to do. Does that make sense? To do that? So those are the things, and that's why. And I want you to know that I'm going to come to another pet peeve topic of mine, very important to me. So, quality of life. Okay? We didn't talk about this that much last time, so I'll talk it about. Remember, I spent all this time talking incontinence. God, if there's one thing that men hate, and I dread it too as well, if I'm in that position, being incontinent. That one gets me. Okay? There's solutions. I don't think we mentioned this last time. I know we talked about the penile prosthesis to get your erections going, okay? Well, there's also something called an artificial urinary sphincter. Anybody heard about this?
Yeah.
What is the last?
Artificial urinary sphincter. Sphincter is a valve. That's a fancy word for a valve. Okay? So think artificial urinary valve.
Wow.
What is it? It's a surgery we do. It takes about an hour and 20 minutes. And we literally go around at the base of the penis and wrap a valve around the tube that the urine goes through, your urethra. Okay? And basically it's exactly what it is. It stays closed, and then there's a little button in your scrotum. When you want to pee, you push the button, you stand in front of the urinal, it gradually opens, you pee, and it's made so that it gradually closes by itself. And that's it. Okay? Yes, sir.
I had the Eurolift, And that did nothing for me. I had the green light surgery after that. That did nothing for me. I get up about 8 times a night to urinate every hour. And this has been going on for a couple of years.
So, here's my first question to you, sir. You've been diagnosed with cancer?
Yes.
Why were those procedures done? Because before you do those procedures, you have to rule out cancer.
Well, that's a good question from a doctor. I don't know what.
So before you touch somebody's prostate, you have to find out whether it's cancer or not. Why? In a green light procedure, okay? What do? Remember that valve I told you that you cut during surgery?
Yeah.
Well, when you get a rotor-rooter, anybody heard that word before?
Absolutely.
Yeah. That means that valve is already gone. That valve is already gone. You need to know that. The valve is gone. So you're already only working with one.
Well, I had TERP and everything turned out fine. I think everything works perfectly.
Oh no, I'm with you. But for example, if somebody's gonna go get radiation, like we were talking in this case and everybody here, if you're gonna get treated, you're not a 2-valver.
So TERP surgery takes out one, eh?
TERP takes out one. Now you're a 1-valver.
Oh, interesting.
Okay? Changes the game a little bit.
Yeah.
You need to know that. You're supposed to rule out prostate cancer. First thing we do, you get a PSA before you touch somebody and you do any bladder outlet procedure. Okay? Now the Urolift. I'm actually one of the few guys, I think it's me and maybe another guy in town who does it. Time and place for it. Time and place. Is it the best procedure for most BPH people? Remember, benign cases? No, it's not. Okay. When do I like to use it? Okay. There are some guys who've got benign prostate who are really big on making sure they have the maximum amount of ejaculate that comes out when they have sex. It's big to them, okay? It defines their manhood. Because what it is it's a zip tie that squishes the prostate. You don't cut the valve. You do not cut the valve, okay? You just squish the prostate and form a channel, open it up so the urine can pass through. So as a result, if the valve is still intact, you don't have what we call the retrograde ejaculation. That's the first person I like to do. Second person I like to do it for is the person who got radiation. Just because you got radiation doesn't mean you're not going to have obstructed urine. No, you can. But remember what I told you about radiation. You still got both sphincters, but they're weaker. By golly, I'm not going to do anything to damage that sphincter, that first one, okay? So what's the nice thing about Urolift? You squish the prostate and you keep that sphincter. So you open up a path, but you maintain the sphincter. Does that make sense? So those are the 2 times you do Urolift. All right. Now, why'd you have multiple procedures? You were diagnosed with cancer.
Yes, I think my Gleason was up to 9. The bottom one was 5, and the top one 4.
Well, guess what? You needed multiple procedures because the prostate kept going because it's not benign prostate. It's cancer that's growing fast.
I had a large prostate.
Because it's cancer.
Yeah.
That's why we don't do TERPs in that situation or green lights. Okay? So that's part of the workup. And that's why I want you guys to understand the mechanism of what's happening here, so you realize the side effects. Okay?
They did 26 biopsies on me, and they were all negative except one, which was the one up to 9.
Wow. No MRI prostate.
I did MRIs.
No, but an MRI guided biopsy.
Yes, I think it was.
Okay, and that came back?
9.
So you can just do the MRI and not have 29 needles in your taint.
Yeah. Well,
Yes, sir.
We're kind of extending the program a little bit. 3 more questions for the doctor.
I have a question about MRIs and what do you find Medicare as far as their ability to pay or wanting to pay or negligence to pay for MRI procedure?
So I'll tell you this about Medicare. I actually like Medicare in the sense that it only pays for procedures when it's proven to be warranted, okay, and appropriate, and science backs it up. Okay? So, Medicare requirement to get an MRI prostate, 2 elevated PSAs, and a negative prostate biopsy, a random. Okay? Because if you had a random prostate biopsy and it showed cancer, you don't need the MRI. But if you have an elevated PSA, which is fishy, and your prostate biopsy came back negative, then they need an MRI because maybe you're going right around the cancer and you need something to target it. And it pays for it all the time.
As a follow-up, just the MRI that the doctor orders, is it enough to just say prostate MRI contrast and no contrast?
It's called an MRI prostate. It's literally a specific kind of MRI. That's all they have to say.
Don't you use the 3T?
Yep, and that's part of the definition of an MRI prostate. It's a very specific MRI to do that because it looks at multiple phases and phase shifts. That's very specific.
2 more. Cyberknife,
Fancy word for radiation.
is that accelerated?
Different kinds. I'll call it cyber spatula. There you go. Same thing. Different. I just invented a new one right now to do that. Same thing.
I thought the cyberknife was 5 times, just 1 week,
Right.
as opposed to 28.
So you sit down a couple more times. It's the same radiation, same side effects.
It's higher dose though.
Higher dose means higher radiation side effects at a time if you're not perfectly targeted in the right area.
And with proton, if you had a hip replacement, can you have proton
You
therapy?
should be able to have it.
Because they question that.
They do question it, but you should be able to have it.
Again, they also have accelerated proton.
So because proton is not radiation, it's more focal, the initial studies don't show that significant side effect, but that's now, I don't have a study to confirm that to you. There's no law.
That's a long, that's like 2 months of treatment.
So this is the problem that I've had with proton, okay? I've had this come up actually several times in the last 2 weeks. You're in Florida here, okay? Let's say you come and you say, Doc, I want to do proton, all right? Your options are what? University of Florida proton in Jacksonville, okay? It's 2 months of treatments, okay? It means what? You need to go live in Jacksonville for 2 months. That's not cheap. That's not tangible for everybody. So there is a financial discrimination for proton, okay? Meaning what? Medicare will pay for it, but not everybody can spend 2 months in Jacksonville.
Yeah.
Well, there's 3 centers on the East Coast.
Yes, to do that. But the one we sent typically is in Jacksonville
Yeah.
to do that.
I have one question. Him and I are going to the same doctor. I don't want to mention his name, but he got 15 pages of printout of, what the doctor's doing and how he's treating him. No, I got nothing. So maybe I'll see him tomorrow and ask him because they told me nothing. Just go see the radiologist.
Well, and that is your right.
Yeah.
Oh, wait, you're right. If the doctor owes you one thing is, tell me what I have and talk to me through it.
Okay.
One last one.
From all that I read, I get confused about success rates. Sometimes you see the words cure rate on procedures. And where do you go to get this information?
Do you really want to read a whole bunch of medical mumbo jumbo?
I
If you
wouldn't
think that's
understand
confusing,
it.
wait until you see.
I wouldn't understand it.
So it's all inside of research studies, randomized control trials, basically trials comparing different treatment models, doing it, and it's embedded within it. The NCCN guideline answers that for you.
Oh, really?
That's what the NCCN is. They've already answered that, and that's why that's their recommendation.
Yeah, the problem is you don't have any easy access to understandable information, but maybe the NCCN.
Go to the nccn.org Then you choose cancer by site, because it has something for every single kind of cancer. You find prostate cancer, and then you go to patient booklet, okay? It won't let you see the doctor one, because you have to sign in for that one. That one you can get for free online. Look at the patient booklet. I just downloaded it yesterday. I think it was 112 pages. My secretary did not like the amount of paper I used.
No, but it's a heck of a lot better than a book that's got 500 pages in it and you can't understand.
So the nice thing about it, it's like a workbook. First, every single thing I talked about, they go over it with pictures. Then they say, okay, what kind do you have? Okay, then you need to go to this page, and it shows you, these are your options. This is what you should be looking for. These are the side effects. It's a really great resource to do that. So, and it's simplified, I would look at that.
First, this is not one of the other ones we've done so far.
Thank you.
Thank you. And I want to thank you very, very much for coming out here and
thank you.
giving us an opportunity to digest through a water hose what you have to present. Thank you very, very much. Gentlemen,
Thank you.
really thank
Whenever
you
I'm
for
asked.
coming out. Hope you picked up a lot of information. I hope this was worthwhile, and we're looking to set something up for November.
Happily.
Thank you.
Happily.
Thanks
All
again,
right.
Doctor.
Anytime. It was a pleasure. Thank you, guys.
Thank you.
Lakewood Ranch just hired a radiologist who specializes in it. Okay? They do the MRI.
Thanks for coming out.
Yes.
Once
To do this.
so far. Yeah. That makes it reduced.
For radiation?
And it's worthwhile.
Yeah.
This is radiation.
Yeah.
No, I've never.
Just like you said.
But it's
I'm really tired.
always a
There's a lot of.
Urologist, one of them solicitors.
Good. I'm very relieved to hear that. You made the trip over here worthwhile.
When you exit here,
You gonna give me any more speeches and be nowhere?
Whenever he asks me, I'll happily come.
Nutritional therapy, is anybody
you need to
doing
get out,
any
there's a red
research
button
on
on the right-hand side of the wall.
So now you're getting on another pet peeve
Front
front
door.
okay? Especially with androgen deprivation therapy, you need to be on calcium supplementation. You need to be monitored for that. Every single person I put on androgen deprivation therapy, I get a bone scan on them, like a lady does when she's in menopause. Make sure you're getting your calcium, and there's a shot I give if you have any kind of metastasis or concern.
No, I'm talking about taking vitamins and so forth.
There is research on it, none of it's been proven to be conclusive.
What about the metformin and turmeric?
None of it's been proven to be correct. Remember, I owe you the science. It has not been proven yet.
Okay.
As soon as it does, I promise I'll be the first one to tell you about it.
I'm doing that.
And do you feel better on it?
I have no symptoms.
Okay. But do you feel good that you're taking the turmeric?
Yeah.
Then tell me.
The question is it slowing the cancer down?
You know,
Because I'm a 3-4.
okay, which is good. But I'll tell you at the same time, if you feel like you're doing something to make it better, that's worth something. Don't underestimate that. It's worth something.
I may be doing nothing.
Maybe. Hey, turmeric's good.
Do you work with the gentleman
I do.
at the office?
No, I'm not in the office.
I got Dr. Barzell, he's my doctor.
Oh.
Oh, so I'll see you in the office. He's my partner.
Is he? Yeah, that's right, too.
He's my partner.
Who's your partner?
Dr. Barzell, the prostate whisperer.
He's the person, I guess.
He's the prostate. He's the man.
Yeah, he's recommended radiation.
And he has the reason. And he actually made him, like, we do joint sessions with patients. He'll tell me, hey, take a look at this guy. He's great about it.
I had a thought tonight listening to you that it's well worth it to me if you will do this. Will you serve as a consultant that I can have review my case more or less?
We're here to help. Whoever your doctor is probably smart, but that's what I'm here to help.
But I
Well,
do charge because
I've seen a fellow one time so far, and I'm going to see him again in 10
you gotta
days.
show him that
He's
you're
part of
strong
your
too.
master
He's not running
group
to
or
me.
whatever,
You're running.
21st century. You're in that group and you're in other groups, I take it.
To do that, yes.
Yeah. Okay. So anyway, if I call, I have your card. If I call this number, can I just schedule an appointment and tell them what that is? And is there a problem if I'm seeing a guy at 21st
So
century?
you're saying a radiation oncologist?
Yes.
Right, okay, he's totally not in our, I mean, he's in our group, but he's not on that same site. He's in a different location. So you're good. You're good, no problem.
Okay.
So you don't need a referral in order to make an appointment?
Call first.
Yeah, oh yeah.
Devil kill you.
You're a good man,
I want
Doctor.
you to text me or dial my phone
on
number just so
here?
I've got your cell.
no.
We can communicate that. I don't have your cell.
Okay.
I just want to make sure that way